Hey, good evening, Dr. Alan Christianson here with you, and thank you all for joining. Looks like we've got a good group here tonight. So this is going to be a fun one. This is going to be all about thyroid medication, something that I've put a lot of time thinking about and managing with lots of people, but haven't done a whole lot of trainings about before. So it's kind of fun to talk about this. You know, meds are not the only answer, obviously, but when people are on them, they're a big part of it, and they need them or not. Many are trying to figure out which ones are best. And many get wrapped up into, changing and trying to pivot and keep hoping that there's going to be one magic blend that makes a big difference for them. And this is really a talk focused for practitioners. And the topic is really about the patients that you see that are already on thyroid medications and not feeling well. The ones that are still struggling with some of the big symptoms. And this is common stuff. Some surveys have shown that natural practitioners, that in many cases, the majority of patients are on thyroid medications. It's sometimes more common than not. And there have been many surveys showing that people in that situation are often not feeling well. They're often really struggling. So I'm excited to share a process, like a process you can take people through and make a really big difference for them. And that's the message, is that these thyroid issues are so reversible in pretty much all cases. You can make a huge difference with some natural basic steps. Sometimes the meds can be part of the solution. Sometimes they're actually getting in the way and they're preventing people from feeling better. Both happens. I'm going to kick off here. My views on this stuff has evolved a lot over time. I started practicing, I got licensed and started up in 96. And at the time, my thought was that if I could just change someone to natural thyroid, all the bad things would go away. They would feel better and weight would just drop off and they get their energy back again. Everything would be fine. Honestly, now that I think about it, I wasn't totally convinced of that because I had seen some shortcomings already before then in residency, but I was somewhat bought into that, to some degree. I get my highlighter going. Yeah, I did certainly think to some degree. And over the years, I do think there are those that'll do better on natural thyroid. And I think definitely there are those to where the medication is part of their solution. And I think many can be a good fit. But most people have come to think, don't need medication. And in most cases, diet therapy alone can make a huge difference. So yeah, my views have evolved, but there's many who do need meds. And if they're on them, even if they don't need them, it's still worth optimizing them. It's still important to get things where they're working as well as possible. And that's a big part of recovery for people. So here's a really quick overview of the process that I'm going to take you all through. Back in my earlier days, I was quick to think that the med change was going to be the answer, and also to think that it was an easy thing, that it would be, just one step and it would all be good. And, it was probably easy on my end as the prescriber, but patients experience, it's a tricky thing. It's never, not never, but it's rarely simple and straightforward. And it often involves a lot of steps and ups and downs. But before I even get going to changing at this point in time, I'd first think, are medications needed? If someone doesn't need medicines, that doesn't mean they can just stop them willy-nilly, of course, but it's a whole different thought process. If the plan is to help them taper and transition and do less or none, that's a whole different thing than someone who's committed to long-term therapy and really needs that. The second thing I'll wonder about, let's say that they need meds. The next thought is really about adherence. If the medicines aren't working, they're not feeling well, are they taking their medicine consistently? And this is number 2 for a reason. We'll talk about that shortly. Then I'll think about lab timing. In most cases, people who are coming in have had some practitioners who have adjusted their medications based on lab tests. And there's so many ways in which those labs can be misleading. People can get goofy results for simple matters of timing. We'll talk about that. Past that, then I'll think about absorption. If someone's not stable, they're not feeling well, are they absorbing their medications properly? And actually, number 2 and number 3 can often look like number 4, and we'll talk about all those. Once we think about those, then I'll think about what's the opportunity for diet and nutraceuticals. Are there things that could help? Are there things that are getting in the way? Is there room to make a difference there? Past that point, and these are things that you don't have to totally complete step 1 before you start step 2, but I really think these are the order of importance and relevance. And in a conversation with someone, you could work through all these in an initial visit. So then if you are thinking that we're covering the bases here, and it really may be time to change in some way, then what about the dosage? In the past, I think I was quick to think about the category and jumping from one category to another. In typical situation for those in natural medicine or prescribers, this is people who are on Synthroid only, T4 only medication, and they want to go on natural thyroid. That was the most common thing. But I don't know, these days I would think more about, are they on a good amount even? Because it is a rather big thing to go from category to category. It's kind of apples and oranges, and you do have to go through a fair amount of titration. And many people, if they were just on the best amounts and they covered these bases, they could do fine on pretty much most any type. So yeah, think about dosage before category or brand. Next up is brand. Sometimes changes from brand to brand can be the whole issue that makes a difference. I don't have a lot of slides on this, so I'll touch on this briefly. Pharmacies can dispense thyroid medication in any brand or generic as they wish. And I always thought that as a prescriber, if I wrote dispense as written, it would get dispensed as written, and that's the brand that the patient would receive. But there have been some studies showing that that really doesn't always happen. So just know that your patients may not be staying on the same brand. And that can be a factor for changing how medications work, especially thyroid medications. You know, the active ingredients are microscopic, and differences in inactive ingredients from brand to brand can translate into differences in therapeutic outcome. And this also takes place within generics. Generics can have the same active ingredients, but they're not going to have the same inactive ingredients from one manufacturer to the next. So someone on a generic, it's kind of like they change brands each time they get a refill in that sense. So yeah, I think a lot about that. And then last up is category. You know, if you've already covered these bases, then it may be time to really think about changing categories. So first question, are they needed? I'm just going to touch on this here. I've talked a bit more about this in other talks, and I'll do more about this in greater detail in the future as well. Yeah, some people need thyroid meds, those with overt hypothyroidism. And I wouldn't actually say they need them per se, but they can stand to benefit. Those who are athyrotic, they do need and they can benefit. People whose thyroid gland was surgically removed or destroyed through radioactive ablation. You know, or in very rare cases, there's a thing called Ord's disease where it shrivels up to pretty much nothing. But yeah, those folks, they need thyroid meds, no debate about that. These people may benefit, may not need, but may benefit. Those with subclinical disease, suboptimal hypothyroidism, you know, these milder forms, the data is strong that, you know, they probably don't benefit as a group. And I know there are individuals that will start meds and feel better for at least a while in these categories. But when there's not a group benefit effect, I've always had to question my own personal experiences. You know, did the person, you know, just like you all, I never would just give thyroid meds. There was always lifestyle changes. I would think about, you know, mind body, cognitive needs, think about nutraceuticals, you know, detox, gut health, all that. And those things are powerful. So when you do a whole lot and someone gets better, you can't assume that it was the meds that did it. So yeah, I definitely have seen patients to where the meds made a big difference, even though they were in these categories, but I don't think it was just the meds. And data like this from the BMJ is showing that those who are here, which is worse than there, meds don't help them feel better. It doesn't lower their thyroid symptoms, doesn't make them less tired. It doesn't help cognitive function. It doesn't improve mortality, cardiovascular disease, but they do have side effects. So yeah, there's really no net benefit in these cases. And briefly, just to mention the process, if it has been ascertained that they are not needed, there's a pretty robust system now for what the process of de-prescribing looks like. And really, it's a matter of just thinking through if the initial rationale was valid, if they were necessary for them, and then going through a process, you know, talking with a patient, giving them some clear expectations, and walking them through a de-prescribing process. Most studies have shown that it's about a 2-month time frame, and somewhere around 84% of people, not who are athyrotic, but who are varying degrees of hypothyroid, even with or without Hashimoto's, that somewhere around 84% can lower their medication successfully without inducing symptoms or abnormal blood levels. And about half of them can come off completely. So yeah, many can do that. Okay, next question I talked about was adherence. So, doctor, my pill's not working well. Are you taking your pill well? And none of us are immune to this, but adherence is difficult for medications. And thyroid meds taken before food, an hour before food, that's not easy to do. That's not an easy thing to do consistently. One large study showed that probably about 67% of people are not very adherent. They're not consistently getting each dose in on a daily basis. 2/3 of people not working. These aren't, it's not that 1/3 is not working, it's 2/3 are probably not getting it consistently. So if someone comes in, they're struggling, levels aren't stable, this is the first thing to think about. This is before you get any further. This is like, is the computer plugged in? So yeah, super important. Won't spend a ton of time on this, but a couple of brief thoughts. A good habit is to really talk through why and how, why the timing matters. And thyroid medication, the active stuff is microscopic, and anything that gets in your belly along with it will make it not work properly. And it's important for it to work properly. This is, when you can talk to your patient about their goals and their concerns, and they might say that their big concern is their hair, their weight, and say, yeah, look, for your hair and your weight, if you take it regularly, it will be more effective for you. If you don't, it won't work consistently. It's a matter of a daily thing. So it's a good thing to talk through and help them understand why it's helping them, rephrase that, say it in a different way, and then have them explain it to you. Okay, let's see that. I want to be sure that you really understood how important this is. So please explain to me why you're taking this and how you're supposed to take it. I want to be totally clear that we understand that well, and have them explain that to you. And that's a funny thing. It's, we all have a feeling of understanding something until we go to tell someone else. And then there's this thing called the illusion of cursory knowledge, where it feels like you know stuff that you don't. But when you go to explain, it's like, oh, yeah, what was that again? And once you do, your understanding is cemented. It's so much better. So yeah, have them explain to you how and why. And then track refill frequency. This is an easy thing. If someone's prescribed a 30-day supply with 2 refills, and you're following up with them, 4 months down the road, and they're not out of medication, something's off. And you can talk to them and say, hey, look, the timing here, I want this to work well for you, but this is something that it's going to work well. It's like the lottery. You got to play to win. And I can see it's a little bit off. So next up is lab timing. We'll touch on this one real quick. And this is a really big deal. So if the labs aren't done in a way to get consistent results, they'll bounce up and down for reasons that won't seem to make sense. You want to test people between 7 to 9 in the morning, before they've had any food, before their medications. If they're menstruating, you want to get the first roughly 8-9 days, or the last 8-9 days, but not mid-cycle. And then at least 3 days after supplements. Take a supplement holiday for 3 days before labs. I'm going to take a little time at the end for questions with y'all. And if there are ones that come up about this, I'll get more detail. But I want to spend more time on the medications, because I've talked about this one before too. So yeah, the timing, huge thing. Individually, each of these can skew scores by like 50%. Collectively, they can cause scores to be 3 or 4 times different than what they would be otherwise. I mean, like a TSH from 0.3 to like 6, not even kidding. If these things are all goofed up, it can give you like completely different results. And so what happens is, if people don't know about these, they'll check one time with, maybe they did check in the morning, maybe they ate, maybe it was after the medication, beginning of the cycle, and still had their supplements. And then next time they test, maybe it's afternoon, didn't just eat, didn't just have the medication then, mid-cycle now, and still had the supplements. And you get totally different results from all that. Next up is malabsorption. Now, this is one that is often suspected and often talked about, and it is a real thing. And it's a big deal too. This is something that makes people not feel well. It raises the risk of thyroid-related complications, and also just causes people to need to change providers pretty frequently. And it's more common when we see chronic inflammatory gastrointestinal diseases. It's not as common otherwise, and I'll touch on that a bit more. But yeah, much more common with inflammatory bowel disease. Adherence is a more common problem than absorption. So when you suspect absorption, think first about adherence in many cases. So we suspect malabsorption when scores are fluctuating a lot, especially when TSH is changing radically, and you're already testing in a way that's giving you consistent results. You're already dialing in your test timing, but still your scores are bouncing up and down. It's just going crazy for no clear reason. That's when you think about there being possible malabsorption. And really clearly, when someone's taking a dose that they shouldn't need, and they're still low, or they're just breaking even, and the dose they're taking should be more than we would expect their physiological requirements to be. Now, how do you figure that out? Yeah, for some reason I put the kilograms per, oh yeah, that's right. I know why I did that. So one number is 1.6 micrograms per kilogram. An easier number I'll often use is about 0.8 micrograms per pound, because we use pounds here. And this is a little different if someone's menstruating, on oral contraceptives, on hormone replacement, or none of the above. So a postmenopausal woman, someone not on hormones, or a male. Those are all people that are going to have lower requirements than someone with a certain amount of estrogen on board. But a general number is about 0.8 micrograms per pound of body weight. So in this case, this is a 140-pound woman, 63 kilograms. Do all our math here, 108 micrograms. So if she were taking 150 micrograms of T4, which is kind of like a grain and a half of natural thyroid, and she was stable on that, if her lab levels were normal, she's probably not absorbing it consistently. That by itself is a concern. It's really common in these cases to where they're not even stable. They're somewhat hypothyroid, and their TSH is elevated. You can see signs of that, and yet their dose should be adequate. Now, 9 times out of 10, I'm seeing if I got a slide. I don't. There actually was, oh, I do have a slide coming up. Yep. 9 times out of 10, it's really not malabsorption. It really is more a matter of adherence or taking it with something that interferes with absorption. And here was a study that was done about that. This was done at one of the Mayo hospitals. This was a couple of years ago. And they pulled together 14 people who had been sent by endocrinology for having malabsorption of thyroid medication. So these are folks where they'd given them doses way above what should be a physiological requirement, and they were still badly hypothyroid. Nothing seemed to help, and no one could figure out what was going on. So what they did was, quite simply, they sat these people down, drew their thyroid levels, gave them a dose of medication, sat there, watched them take it, watched them swallow it, and then drew blood levels again several more times over the next few hours. So how did it work in a controlled setting? Well, in this study, 13 out of those 14 cases had perfectly normal blood responses to their medication. It worked just fine. There was no problem at all when they were observed to take it. One person out of the 14 truly did have malabsorption. But yeah, 13 out of the 14, it worked just fine. So it was some issue of adherence. They weren't taking it daily, or they weren't taking it away from food, or they were taking it with some coffee and creamer, or calcium fortified orange juice, or you name it. And these are people that had gone through many, many steps of diagnosis and treatment. They were recruited into a study. They were trying to get it right, and they were told many times how this should work. But I just want to impress upon you all how tough adherence can be for people, and how even if you talk to someone 3 or 4 times about how it all works and how to take it, it may not have really registered, or they may not be taking it as correctly as they think they are. But when someone takes their medication in controlled settings, it pretty much always works, even if before then it did not. So what are some considerations about things that may be contributing to malabsorption? Well, one big one can be the inactive ingredients, and there are a lot. They're not that radically different. So I've got some T4 medication, T3 only, natural desiccated thyroid. There's not a whole lot of differences here as far as how many. There are differences as far as which ones. You can see a big difference for Tirosint products. Those two really do stand out. We used to have WP thyroid, and that one kind of looked like Tirosint in that there wasn't a lot of stuff in those rows. That one's not around. I'll talk more about that and some alternatives for it. But in most cases, brand to brand, you may have some different things, but not like nothing. There's still a lot of stuff there. One little trick, there are those two where the colors may be an issue, the artificial colors, and they are present in all of these brands with the exception of 50 micrograms. Yeah, 50 micrograms. I'm going to give you guys a link here. I think I've got this one somewhere where you can get to it pretty easily. I'm just going to copy and paste this link and test this real quick. Yeah, okay, I'll share this one afterward. But the trick is that 50 micrograms, 50 micrograms is one that doesn't have colors. So that takes a bunch of stuff down for T4. But otherwise, a lot of things there. Those who do malabsorb, there's been several studies about the difference between pure products. I'm not getting paid to talk about Tirosint here, but I am a fan. And they make gel caps and liquid solutions. So those who do malabsorb, that can be a better way to go. I'll also talk about some options that are similar in terms of natural thyroid when I come to that section. And then we think too about medications that interfere, things that have immediate effects. This is a very partial list, but these are things that can have immediate interactions and also delayed interactions. I'll talk more about things that do that, but these are all medications that even hours after taking a thyroid medicine can make the thyroid medicine not absorb properly. So if someone really does need to be on something in these categories, they may think about nighttime dosing for their thyroid medication. There have been about probably half a dozen studies on nighttime dosing. The data is mixed. None of the studies say that it's catastrophic. None of them say that it's just a wreck. Most studies suggest that it's about the same, no radical differences. A few suggest that it may be a little bit less absorbed or a little bit less effective in terms of the same scores. So you put it all together and it's probably okay, but I wouldn't make it the first choice. So yeah, if someone really is needing the medications, or if they really can't do that 1 hour NPO thing, then bedtime is a consideration for them. And along those lines, there are other things that will make the medication not absorb, even if it's taken some time afterward. Antacids, I mentioned some prescription ones in the last slide. Calcium supplements. Now, this is not all, but this is more so those that are insoluble. So this is things like Algical or bone-derived calcium, also coral calcium, versions of it, oyster shell calcium, calcium carbonate, the types that are less soluble in water. These are ones that may impair thyroid absorption even like 6 hours later. This is a weird one, but there have been studies saying that coffee may be a factor as much as 6 to 10 hours afterward. So if someone really is appearing to malabsorb, that's a common offender. Now, I mentioned Tirosint before. There have been studies suggesting that it's not impacted by this, and also studies suggesting that the liquid versions can be taken 15 minutes prior to a meal. So that can be a good option in cases like these as well. High fiber diets, yeah, not so much throughout the day, but immediately afterward. And this is more so concentrated fibers like wheat bran or oat bran, not as much in just actual food sources. But yeah, things or like taking Metamucil, psyllium seed husk. So in the hours afterward, this could also affect absorption for those who are struggling more so that way. And another consideration is that sometimes if things look like they're not absorbing, it may be because the medication or other things they're taking are skewing their labs. So these are things that don't change absorption, but they change how labs end up working. And this is because the chemistry of these compounds affect the chemistry of lab analysis of thyroid analytes. So biotin's a big one. And this is pretty wild, but this was a patient to where you can see that off or on biotin, that her scores were changing from 2 to 0.02, 0.08. So the same person, the same dose, but biotin changed the levels. And this is not biotin hurting the thyroid. This is not biotin causing thyroid problems, making the medication work weird, nothing. It just goofs up the blood test. So you got to give this stuff a break for a couple of days beforehand for a decent reading. And I want to touch too, so thinking about the steps. So now we've talked through the idea of absorption, malabsorption, those other issues. Then I think about nutraceutical support. In the goal of helping someone feel better, we've got so much data that nutraceuticals can be helpful. And this is vitamins, minerals, botanical compounds, various functional food items. And we know that these things can lower hypothyroid symptoms. They can help the body utilize and optimize thyroid hormones, and they can lower the overall immune response. So someone in a case like this who's hypothyroid, an easy combo is the Thyroid Daily, the T2, T3 converter. I'll mention that a bit more. Hypothyroid support. And then if they also have autoimmunity, whether that's Graves or Hashimoto's, then antibody support is appropriate. Now, helping their body convert, this is relevant for symptoms in the case of T3 and T2, but also for blood levels in the case of T3, because we can measure that one. But if someone's on a dose that should be okay for them, they're taking it well, they're getting stable enough amounts, but you're still seeing these persistent symptoms show up. Especially a big one can be hair loss here, the fatigue as well, fatty liver, lipids being really high. These are all signs of T2 lacking. I'll talk a little more about T2 in isolation, but these are all things that without changing a medication, without changing a dose, you can help the person's body use better. And this is something that's become really clear to me, is that the body has a lot of ways it can rearrange these thyroid hormones. And if there's even like a reasonable amount going into it from what you're making or what you're taking, the body should be able to make use of that well. So yeah, I think less and less about trying to make the dose just precise, because healthy people don't have precise daily amounts of thyroid hormone. They make different amounts and their bodies convert and arrange as need be. So the thought is always, how do you help someone mimic the healthy? And this is one simple way, is supplying the various cofactors that help all the methods of peripheral metabolism and the deiodinase enzymes. So now we've gone through these steps, and now we're thinking about dosages and if someone's on a dose that's right for them. And with this, we think about various dosing targets. Now, I want to really make it clear, there's a lot of these charts out there. These are not too radically different. I'll mention some distinctions you'll see, but this is not a range outside of which one would start medication. This is not me saying that if somebody is not here, they got to go on medication, because it's probably not going to help. That's back to that whole thing about overt hypothyroidism and athyrotic people. But when someone is on medication and they need it, they're different. And someone can develop symptoms not on medication outside this range, but that doesn't mean that medication will reverse those symptoms, even if it moves them back into the range. That's a one small step for a man, giant leap for mankind. That's a small sentence. It took me a lot of years to wrap my head around that, to really figure that out, and then to conceptualize it and really realize that and understand that that was true. So yeah, someone can have a TSH of 4, and that can cause weight gain, and that can cause depression, and that can worsen their health in a lot of ways. And you would think that if we could medicate them and push them down to 1, that all that stuff would go away. But no, taking is not making. Exogenous is not the same as endogenous. So these optimal ranges are very important for those who need medication, but these are not where you would initiate medication for someone just because they're outside of that. So we think about TSH, and a lot of data has shown that healthy people have a low normal TSH. They're not below range, and they're not on the high side of it. And this does change a bit the further someone gets past their 60s. But for adults below 60, most are healthier here. And there's a lot of data saying that, and those on thyroid medication will function better when they're generally in this range. Now, one big caveat, this is a rather narrow target, and I want to own the fact that it's a bit of a moving target. So I talked before about the rules of test timing and the medications that goof it up and how biotin ruins everything, all that stuff. So what happens if you do it perfectly? How consistent are thyroid labs when you do it perfectly? Well, there's 4 different assays out for TSH scores in the US, and there are just inherent variations. And those variations are different for the lowest scores, the moderate scores, or the highest scores. But those within the normal range, the unavoidable random variation is a little over a full point. So please know that you won't always have someone right there, no matter how well things work. They will bounce around in ways that you can't get around, because that's just how the labs play out. They bounce around by at least a full point. But yeah, that's a good general target. I always think that if someone is doing well, generally stable, and all of a sudden now they're just a bit below or a bit above, 9 times out of 10, I'd rather just watch them and retest in a few more months before even doing anything, because it may have just been that normal lab variability. It may not have been relevant at all. So yeah, just pause and get another check if they're slightly outside of your target. Now, T3, T4, I won't spend a ton of time on these. I did a bit more in depth on one of my last webinars about the whole T3 story. General rule, there is a lot of variation in these things in healthy people. You can be higher or lower. There's a popular idea which thinks that if a healthy TSH is low, then therefore a healthy T3 and T4 must be high. And I get that that sounds like a simple rule, but this is another case to where the truth defies simple rules. Healthy people don't always have, even though they often have a lower TSH, they don't often have a high T3 or a high T4. And a lot of data shows that those who generally do have higher T3 levels have greater risks for breast cancer, obesity, and quite a few other problems. So yeah, I don't push to the high end of the range. There's a pretty broad range the body can work around. So here's the next big step. Now we're going to roll up our sleeves. We've thought about doses. We've already dialed in what they're on. We've got it kept about where it should be, and they're still not doing their best. Now we think about changing categories. Now we're going to take the big step to change categories altogether. And in considering this, there's a lot of things to think about. Of course, there's the clinical outcome. We want to do this because we think they may feel better by doing so. But what happens if they can't get their medication next month? This one makes me nuts because a lot of medications that I've found effective and really used a lot have been inconsistently available. And it breaks my heart when I've really told someone, look, this change can be helpful for you, and it is, and then they can't get it. That sucks. It sucks to be on both ends of that, especially the patient's end. So we got to take that into account somewhere along the way, is have them on things that they can stay on and they can get consistently. Quality control. Are they on something that's made in a way that batch to batch will be the same potency and the same inactive ingredients? Adherence. Is what they're taking going to be easy enough for them to use to where they can stick with it? This is where the timing comes up again. The inactive ingredients, especially for those that may be malabsorbing, got to think about those. And people can also have concerns about particular ingredients for other reasons, and their concerns are valid. Last but not least, cost effectiveness. A lot of things on the market, and there can be a huge range in the cost of different medications. You got to take that into account. This is the reality of life for many people. Not everyone has all their medications covered, and a big cost difference can be something that just won't work for someone. So we've got to think about all these factors when changing categories of a medication. So what are the categories we've got to pick from? Well, here's what we have to work with. I'm going to talk about all of these. There are over-the-counter thyroid meds. I'll mention those. We've got compounded. Then there are the manufactured medications, and they can be synthetic and natural, as can the compounded. And I'll briefly touch on all of these. Before I get in, I'm going to throw my cards on the table and just say from experience and medical literature, here's what's come to be my preferences over the years. First thing is brand name over generic. I've actually seen some recent papers arguing this may not be as big of a deal as we thought it was. So we'll watch on that one. But I have been trained to and generally been consistent for keep people on one brand and not letting them have their brands changed on them. People that come to see me, most have been on T4 monotherapy and struggled with that. And in many cases, they've had a bias wanting to go to natural thyroid. So that's something that I've done a lot of, and I'm quite comfortable with natural thyroid as monotherapy. I do think for many people, T4 is reasonable for monotherapy. So yeah, brand name, not generic, and just one pill, either natural thyroid or T4. We'll talk a lot more about all these in more detail. Next up would be natural thyroid plus some more T4. In some cases, people don't do well with the amount of T3 in natural thyroid. And the easiest way is to dilute that by adding in more T4. I'll touch more on that in the natural thyroid section. Past this point, there are those who do not wish to consume animal products or things that are not kosher. And desiccated thyroid is an animal product and it's not kosher. So then we think about pre-made T4 and T3, Synthroid and Cytomel. Next up, I would think about compounded natural thyroid, and I'll talk more about some particulars that way. Not preferred, T3 monotherapy, and I can answer questions about that, about why not. Compounded over-the-counter thyroid or compounded synthetic, and I'll touch on all those in a moment. Before I go further on category, this is an image that really useful thing. This is going to show in a row what are the relative potencies from all these different categories. Now, these are relative potencies, and I've got to say that to some extent, these things are apples and oranges. So T4 by itself, T3 by itself, natural thyroid. Again, I don't encourage someone to be on T3 only, but in many cases, a patient that you inherit may be on T3 only, and you'll need to know what they're taking and what that looks like in a different category of medication. So general rule of thumb is that we call these T4 equivalents, and not to bias T4 as being better, but just use that as a common level of units. So 100 micrograms of T4 is about a grain of natural thyroid. So for some brands, that's 60 milligrams. I'll talk about one new brand on the market. Some will call that 65, but the grain is the consistent thing between brands. So yeah, 100 micrograms of T4 is about a grain of natural thyroid, and it's about 25 micrograms of T3. And if there was a stronger word for about, I would use it because people will not merrily go from one to the other without there being changes in blood levels and changes in symptoms. But these are ballpark correlations. So if a patient is really struggling on 100 micrograms of T4 and it's time to switch them to natural thyroid, and maybe their levels are also low, 1 grain is a reasonable starting dose in a case like that. But you got to test, you got to expect to make a fair amount of change. So yeah, these are relative comparisons. A little more use about what this chart means. The blanks are potencies that are not available by that product. So yeah, no one makes a 7.5 milligram natural thyroid. And we see that amongst brands, some have more potencies available and some have others. Compounded, of course, you could make whatever. The color code is generally just that these doses here are almost always supraphysiologic. These are pretty much more than the human body would make, barring someone who's really big. So kind of a ballpark number you can think about is if someone's, say, 120 pounds or so, and they don't have a thyroid, they're probably going to need somewhere around like this much, So when someone's here and they're not 240 pounds, something ain't right. They're not taking it, they're not absorbing it, or it's just simply an excessive dose for them. And you can see that by their blood levels. But yeah, these, orange, red, scary red, these are doses that aren't going to be needed unless someone's really large. Their body size is quite large. So let's jump into categories here. First one is over the counter. There are non-prescription bovine, so cow-derived natural desiccated thyroid products. And these things, I'll again throw my cards out. I'm not a fan. And I also, I think they're unethical. So the companies will often make it out like these things don't have thyroid hormone whenever regulators ask, whenever they put out statements to the public, but they all, wink, wink, nudge, nudge, will say this one equals about this much natural thyroid. They do have active hormone. There's really no way to sneak inside of the tablet and pull out the active hormone. I've talked to chemists who make thyroid medications. They said no one knows how that would be possible. And we've seen this on assays. So a group of these products was taken not that long ago and assayed. And what they found was that these things had a lot of active thyroid hormone. The amounts were completely inconsistent from capsule to capsule and from bottle to bottle, but there was a lot of stuff there. And in some cases, more than you would probably take via prescription when you would take a labeled amount. So yeah, these things have hormone, but there's no standardization whatsoever. And as we go through categories, the standardization is a big deal because the active stuff is microscopic. So small variances can be like, life or death. So yeah, not a fan. There's the concern too about prion contamination, these precursor protovirus type genetic little fragments. And that's because these are found from bovine brain tissue. So mad cow disease, bovine spongiform encephalopathy. Now, of course, the thyroid is not the brain, but when cows are killed for these purposes, it's impact force and brain tissue moves all throughout the head and neck compartment. So these are things that I just wouldn't take. You could get prion contamination. It can sit around for 34 years, no kidding. And then all of a sudden eat your brain like Jell-O. So yeah, pretty scary. Another similar category, we have non-prescription synthetic T2 products that are readily available over the counter. And I talked before about some of the ways that T2 can be a benefit. And it's totally true that T2 is a useful thing inside the human body. And there are products that have biologically active T2. These are active thyroid hormones. These are not in any conceptual way different from prescription T4 or T3. They're not standardized. We don't really know how much to take. We have no way of testing for it. And here's the wrinkle. There was a study done about these products. And we know that T2, if you add in T2, in the short term, it may do useful things like boost the metabolic rate. However, if you give enough T2 to do those sort of useful things, you're also going to see cardiac hypertrophy and other detrimental effects upon the hypothalamic pituitary thyroid axis. So yeah, before you get enough to be useful, you're going to have harm and side effects. So the study actually showed that that doses that were low enough not to be of harm wouldn't be of benefit, but the doses that were high enough to be beneficial in those ways would give detrimental effects upon cardiac health. And papers have shown cardiomyopathy. These are commonly abused by bodybuilders. They are given by some thyroid experts, but this is a synthetic hormone. And this is something that when the body makes it, it's very helpful, but it's not the same as the body making it. We don't know how much people need. We have no way to test how much they're getting. It doesn't register in blood tests when they're taking T2 in a synthetic form like that. So yeah, I love to help someone make their own T2. There is a small amount of T2 naturally occurring in natural desiccated thyroid. There's a lot of naturals in one sentence, and I think that's a useful thing in it. There's not a huge amount there, but the amount that we find in these products can be a great deal higher. So now let's talk about compounded. So some cool things about compounded medications is that continuous dosage selection. Any number you can think of, anytime that you want to go up or down by just a hint, you can do that. And that's awesome. You can have control over the inactive ingredients. Well, kind of a positive thing, there's no product recalls. There's never been recalls on compounded medication. So a patient wouldn't have to think about their medication being unavailable because of a recall. And the drawbacks here, they correlate. I'm going to get my control back here quick. Yeah, turn that thing off because this is in the way. There we go. So the negatives are correlated in the sense that there's no recalls because there's no mandatory post-production analysis, and that's why they're not recalled. The pharmacokinetics, this is interesting, I'll talk about this later, but the way in which sustained release compounded thyroid is absorbed is actually not sustained release. This has been studied. And there are concerns about stability, how long it stays viable after it's made. I'll touch on all those. So with compounded options, we've got both synthetic and natural desiccated thyroid. Synthetic is just T3 or T4 in isolation, as you would find like in Cytomel or Synthroid respectively. And natural desiccated thyroid, this is what we would call, ARM or brand. This is porcine freeze-dried desiccated thyroid powder. And it's actually the same kind of powder that is bought by manufacturers when they tablet it. When they do buy in tablet, they have to test for potency, but that's not required for compounded. So for synthetic compounded medication, that can be with diluted active ingredients, which that means that each microgram of T4 is in 1 milligram of a carrier base, and that's the PCCA process. If one were to use compounded thyroid medications, I would highly encourage using PCCA process. It's easier to measure. It's no exaggeration, 1,000 times easier to measure because it's diluted 1,000-fold. There are also undiluted T3 and T4 products available. Difficult just because there are case reports each year of people that are harmed by these pretty badly because they're hard to make right. So inactive ingredients, well, they can change those and some will make sustained release on purpose. But there have been studies done on the sustained release with methylcellulose. And what they've shown is that it actually doesn't change absorption. So yeah, the pharmacokinetics of sustained release T3 medication is not sustained release. This paper shows a curve of blood levels after using sustained release T3 and the same person taking the same amount of a immediate release pre-made product like Cytomel. The curves are identical. So yeah, there's no difference. It's a valid goal, it's a valid idea, but so far commercially made compounded sustained release products don't have sustained release pharmacokinetics. And I mentioned about stability and about just how long these things last. So this is a concern, different pharmacies, and this is the potency in T4 products over the course of 34 days. And we can see that the potency, first off, every one of these should start at 100 and remain at 100. So one quick thing to see is that they're not at 100 to begin with, they're above or below, but then they change a lot. You can see a pretty clear trend. Some start out very subpotent and end up much more so. And some start out low and kind of stay there, but there is a concern about just degradation. And that's a problem about just the compounding process. And quick update about natural desiccated thyroid. There is an FDA action going on that's not moved forward since this letter was written last fall, but that is a process that may be unavailable in the near term. So yeah. And now to contrast with legend drugs. So Positives is that you've got post-production analysis, and that allows for 10% max variability. Not that precise in all honesty, but there's at least a target. Negatives are that we can't pick the dose options. We got to use it with what there is that is made. And the inactive ingredients are just fixed per product. You can't really tailor those other than by choosing a product over another. And last but not least, these things do get recalls. And so if someone gets going on one they like and it's not available, that just sucks all around. One thing to mention as far as legend drugs, there used to be a thing called Thyrolar, but there's not. And that was a T3, T4 pre-made combo that went by the wayside a few years back. So pre-made meds, the main thing that's common is with T4 monotherapy. And most groups consider this treatment of choice for these various categories. Some thoughts about T4 monotherapy. This is stuff that's readily available. You can do pretty well at daily dosing. You've got a certain number of potency options. There are recalls, and people often grouse about natural thyroid. There are more recalls for the synthetics. They happen quite commonly. So this is something that you can't really get away from. I mentioned before about the 50 microgram trick, and that's just here. If someone wants to avoid colors, they can use 50 microgram potencies and use a couple of those. You can't adjust that very much. That's a drawback. That's one way to get away from the colors. These are an oral and injections. Injections really aren't used besides inpatient type purposes, and even then quite rarely. So products in the market, here's what we've got in the US, Euthyrox, Levo-T. I won't go through all of these per se. By and large, pretty similar, differences on inactive ingredients, but not radical differences otherwise. But nonetheless, the inactive differences can mean that in one person, if they go from one to the next, that may change the efficacy for them. So if someone's stable on a brand, they're better off sticking with that brand. The Tirosint is the one that's really different as far as the inactives here. Then we've got synthetic T3 products. And generically, we got leothyronine, Cytomel, various compounded forms, again, PCCA being preferred. And T3 is something to where its absorption is a little slower than people think. And there's a difference between metabolism and absorption. I just want to touch on that briefly. So the metabolism is how quickly you eliminate a medication. And that's what you base dosing frequencies off of, is how long it takes to get out of your body. The absorption is how quick it takes to achieve a peak blood level. Many think about needing to take T3 many times throughout the day based upon absorption. But absorption is not the marker that dictates dose frequency. Metabolism is. And yeah, metabolism is the course of 24 to 36 hours. So daily dosing is reasonable. There are some forms of T3 called T3 sulfate that are undergoing some advanced stage human clinical trials. There may be products in the market with those, and they may create more stable serum levels. But, twice, 3 times daily absorption is not necessary because, dosing is not necessary because the metabolism is slow enough. I'm going to talk about NDT for a couple of minutes. In terms of timing, yeah, I'll probably be finishing up within about 5-10 minutes or so, and I'll take a couple of questions. I see some things in chat. Anyone's welcome to raise your hands as well, and I'll just take any live ones that come up as we're finishing up. Yeah, natural thyroid, been around a long time, also called DTE, desiccated thyroid extract. Not that long ago, there were many versions of this. So thyroglobulin was a product on the market up until I think like the 80s. Desiccated thyroid, desiccated thyroid extract. They were actually different things, thyroid extract. They were not all the same as NDT. They were variations of natural thyroid extracts. And for quite some time, this was just thyroid medication. This was the stuff that was used. Up until about 1980, this was a treatment of choice for hypothyroidism. You've got various things in here, the T4, T3, and T2, also thyroglobulin, which is biologically active by itself, and some iodine in there, and also calcitonin. These are all parts of that. And there are other things called thyronamines, which are compounds like these that are biologically active, but not things that we can measure. And there's more than a dozen of them. We know that many of them do have biologic activity. Some have distinct receptors, some have distinct effects, and these are things found in natural thyroid. So yeah. As far as current products, there's one more I'll mention, which I do have it up here. Yeah, so we've got a couple. Right now, it's primarily these 3 on the market. Nature Thyroid WP, not commercially available as themselves. Now, Specialty Process is a company that supplies the powder that used to be made into Nature Thyroid and WP. So one workaround, there are pharmacies that buy natural desiccated thyroid powder from Specialty Process, and they can then compound that and get a pretty good approximation of WP thyroid specifically. Some of these pharmacies will do third-party post-production analysis. I think that's then reasonable. So if they are using, and there is also a step that Specialty takes to analyze their potency in terms of active hormone, which is not done for the raw materials that go into Armor or NP. So Armor and NP still have to test potency after production, but their raw materials aren't vetted beforehand. So a lot more of their batches have to become discarded. But Specialty Process does do potency testing beforehand, and then some pharmacies can compound that and do potency testing afterward. I think it's a reasonable option for those that did much better on these, even though they're not currently available. I'll touch on this one just briefly. Some reasons to think about natural thyroid as an option. This was an interesting thing. This was a pretty big survey, like 12,000 patients. I forgot. It was 2018. Maybe that's where I'm getting that number from. It was at least 12,000 people, I think, altogether, but asking about treatment satisfaction. And surprisingly, this was patients who had come in from regular endocrinology practices and were given a survey from the American Thyroid Association. Upwards of a third of them were taking natural thyroid. That number surprised me. I didn't think it was going to be that high. And the take home here is, how satisfied are you with your treatment? 7 being there's actually a 1 to 10 scale. It's not showing it. It was a 1 to 10 scale. A 10 was the most satisfied, right? No one did great. So I just got to own that from the get-go. No one got like a plus on the report card you put on the refrigerator. But there was a trend to where those that had T3 added did better than those on T4 only. And those on desiccated thyroid extract did better than those on T3 and T4. So they did have the best satisfaction overall. It could have been higher. It wasn't that this solved everyone's problems, but as a group effect, there was a more positive response overall as the group. And yeah, so 29%, actually about a third, were on natural thyroid, which was rather surprising to me. A couple of thoughts about it really quick. So the T3, T4 ratios, kind of a non-issue. There's a lot of ways you can say what is the best ratio for humans, but if you look at the ratio found in the bloodstream of the active hormones, it's like 3.5 to 1. So 4 to 1 is not unreasonable. The body secretes somewhere around a 5 to 1 ratio, 5 to 4 to 1 ratio, like 10 to 20%. So that's also quite similar. But there are those who do better on less T3 relative to T4. Thoughts about autoimmune disease, no big issues that way. Variability, that is a concern, not inherently different than the synthetics, but that's a concern for all medications. And yes, no detriment towards thyroid antibodies. In fact, studies have shown that the use of oral thyroglobulin may help create tolerance to thyroid protein, so lower overall autoimmunity. Another big question has been if it's inconsistent, and you'll hear this a lot. Doctors will say they don't use it because it's not consistent. It varies too much from batch to batch. Big study was done a couple of years ago, actually just, 2020, and it looked at how stable natural thyroid was compared to synthetic thyroid medication. And there was no difference. There was no way in which those on natural thyroid had less stable blood levels than those on synthetic thyroid. So, yeah. So repeat the preferred options that I mentioned. Yeah, I like NDT or T4 monotherapy for those that do need it. For those that just subjectively feel that they have too many hyperthyroid side effects, even on a reasonable dosage, I'll think about adding more T4 or doing T4 only for them. This is probably, crude experience, 10 to 15% of patients, maybe 10 to 20% of patients are in a category in which they do better with just T4 or with T4 plus natural thyroid. Those who are kosher, vegan, then I would think about the isolates, the legend form isolates, or those who did very well before on a brand that's not available like WP. The great option for them is compounded natural desiccated thyroid, especially if it's with that powder. And again, this was like the last step, is like changing. We first think about, are the meds needed? Are they taking them well? Are the labs timed? How well are they absorbed? these are all things I would think about before changing categories completely. So yeah. All right, that's what I had. I did a whole lot of talking there. I'm going to stop the slide. I saw one or two things pop in the chat. I'll take a look at those. And you all are also welcome to raise hands for other questions or put more things in chat. I'll take a couple minutes and cover what I can here. Just a couple things here. Is TSH 2.5 too high in your opinion? Yeah, great question. So back to the idea about optimal, too high. In terms of context, there is data saying that specifically in the case of fertility, that being above 2 may impair effectiveness of fertility treatment. So that's like the only case I can think of where one could justify initiating therapy for a TSH of 2.5. But someone who is on therapy and is committed to therapy, they may be more symptomatic at 2.5 than they would be at 2 or 1.5. Having said that, again, I have made the point about how the TSH will always fluctuate by even a full point or more. So if that 2.5 is bouncing around between 2.5, 3, 3.5, and someone is needing therapy, that would be a totally rational way to think about a small dose increase. And it's kind of odd, but when someone is that close to target, I really would think about the smallest possible dose increase. One more plug about Tirosint is that they make a 13 microgram potency medication. And that's cool. That's basically a 1/8 grain of a dosage. That's nice to be able to move it by those tiny little steps like that. And one more here. I see just one more question, you guys. There's a bunch of folks still on, and I don't see raised hands, but I see just one more question. So if you guys have anything else to ask, plug it on in right now. Otherwise, I'm going to stop pretty quick. How does someone with few symptoms, cold hands, feet, hair loss, know if they even need thyroid meds? Yeah, great question. And briefly, I'll go through this one. So needing thyroid meds, yeah, we wouldn't base that on symptoms. We would base that upon their thyroid diagnosis. And if going into this whole thing, they were overtly hypothyroid, meaning their TSH was markedly elevated. And there's not really an exact threshold for this, but it's a very elevated TSH plus a low level of T4. And low is not low normal, but well below range. So that's overt hypothyroidism. And when someone's there, they may benefit from thyroid medication. It's not their only option. They can still pursue diet therapy. And I really outlined this in the thyroid reset diet, but they've got that option of going on medications. And people who were at lesser levels, there's not data saying that medications would consistently help their symptoms. So you could still see, it still can be the case that a thyroid could cause symptoms like those. It could still cause them, but medication wouldn't necessarily help if they weren't on medication. If they are on medication and we've exhausted the other steps, then yes, we could certainly consider changing dosage in ways that might improve those symptoms. So hopefully that made sense. If it wasn't clear enough, let me know. I can go deeper in that one. What do you try prior to thyroid medications? Yeah, great question. And really, I would think about those steps I talked about before, but first and foremost, really diet therapy. So there's been now about 20,000 studies on the effect of diet and thyroid disease. And about a dozen of those studies relate to gluten. Basically, they've shown that those with celiac disease need to avoid gluten. And there's a high overlap between celiac disease and thyroid disease. There's no study saying that going gluten-free helps thyroid function, even in those who have celiac. So with celiac, they should avoid it, but there's no direct way of saying it changes thyroid function. We've got a couple of studies saying that there's a lower rate of thyroid disease in those who are vegan. There's one study on AIP diet and showed that it just didn't change thyroid markers. There was no change in antibodies, TSH or T4 scores. There was a subjective improvement in well-being in some participants, but no change in thyroid markers. So we've got those here. And then we've got 19,900 studies on dietary iodine and its effects upon thyroid function. And they've shown that getting below a certain window can reverse thyroid disease for about 60 to 80% of adults. So that includes overt hypothyroidism, subclinical and suboptimal thyroid levels. So yeah, we've got controlled human studies showing that it full on reverses it. So that's the first thing I would try. And yeah, studies have shown that those who have TSH scores of like 14 to 50, that they can normalize or they can radically improve in as quickly as a couple of months. And it's not even a very restrictive process. It's a matter of really just identifying the big outlying sources of iodine, and they're pretty easy to work around. There's tons of foods in all categories that are not crazy high in this. So Emily, I saw that one about thoughts on iodine. That's a Cliff's Notes. I could go on for so long. Iodine tests are not accurate, not helpful. But yeah, in 92, we had 112 nations on the earth that were categorized as severely iodine deficient. By 2014, that 112 number was brought down to 0. We have none there now. So over those decades, the rate of excess iodine went up by 26-fold in many countries. The overall intake in the American diet went up by about 3-fold. And 23 out of the 25 top dietary sources of iodine either doubled or tripled. So it's not the bad guy. We need some. It's just that we need a certain amount. And those prone to thyroid disease have problems with even a slight amount above a narrow range, probably about like 50 to 200 micrograms. So yeah, I could talk a long time about that. I'd be happy to give more details. So if there's specific questions about that, please put that up. Another one here, have high antibodies. Does this mean I definitely have Hashimoto's, and how important to lower antibodies? You know, great question. Let me see if I can grab a link of a super detailed webinar I did on that topic. I'll give you a brief answer, but there's so much more to say about that. Okay. Yeah, here it is. Oh, no, that's the precursor for it. Well, I will put that up afterwards. Oh, here's the whole series. Okay. Here's a series I did that's on YouTube about thyroid antibodies. So way more detail. Short version is that mild elevations are actually normal and healthy. The body uses thyroid antibodies, believe it or not, to get rid of old thyroid cells and misbehaving thyroid cells. So a little bit is fine, but here's the thing that's kind of frustrating. There's not an exact number. So the more you get up in the triple digits, definitely the quadruple digits, they are a problem. And this is bizarre, but the least relevant thing they do is hurt your thyroid. They do elevate the risk of the thyroid slowing down, but minimally, really not very much at all. But they do cause other problems. They can cause all these thyroid symptoms even without ever changing thyroid levels. So they are relevant generally in the 3 digits, definitely in the 4 digits, and they can affect health in lots of bizarre ways. Heart disease, autism risk in kids, all kinds of stuff. Do you have a thyroid video you could share with the general public and patients? For sure, that when I put up with the antibodies, you're welcome to. I've got about 1,000 blogs and videos up. If you think of a topic and you put in Alan Christianson topic X, there's probably a blog or a video about that, and you're completely welcome to share those with general public and patients. So yeah. I've only heard of supplementing iodine for hypothyroid. You're saying the concern is excess iodine to lower. Yes, further resources to learn about this would be appreciated. Sure. So one thing, the most depth is in the Thyroid Reset Diet. I'm just going to put the name in here wherever books are sold. I told the story in a whole bunch of detail. There's a popular view in natural medicine that people need more iodine rather than less. I talked about this one in pretty good detail in a blog that I'll drop up here in a moment. I'm just getting this link. Yeah, this is it. Do we need iodine? Do we need more or less? And this goes through, there's a video, there's also a really detailed blog here, and this is free stuff about why there's popular ideas saying we need more and what does the research tell us about that. And I just completely share my experience with these ideas and how they were shared with me, how I reacted to them, how my views evolved as I spent more time in the literature. So yeah, you can go really deep in that one and find out a lot about it. Okay, let me grab one more here. Speak of how higher antibodies may not necessarily mean worse symptoms of Hashimoto's. Most women, no, I would argue that when they're higher, if they're barely high, they may not be relevant, but when they are elevated, they can be big drivers of symptoms with Hashimoto's. And in fact, I would argue that in most cases, they're bigger drivers of symptoms than thyroid levels are. And this is part of why thyroid medications fail to help people feel better so often, because the medications don't change the antibodies. And the antibodies are huge drivers of anxiety, swelling, weight gain, fatigue. I mentioned cardiac risks, also problems with fertility. So, and this is all in people that have perfectly normal thyroid levels. So when the thyroid's functioning perfectly, the antibodies by themselves can cause all of these problems. In fact, I want to give you another resource about that. This is a monograph that I wrote on that topic. So on thyroid-specific formulations, I've got a whole lot of resources for providers, and I'll give you guys a link to that. And I'll show you specifically the one that I'm about to refer to here. Where in the heck did I put that? I'm on the site here. Best steps to lower antibodies. I will, yes, I will, good one. I will cover that one too real quick. You know, I just had this link. Here it is, provider training. Yep. So here's a whole bunch of provider training on all sorts of things like how to lower antibodies. And specifically, there is a monograph for antibody support. And this talks all about how to lower antibodies and how nutraceuticals can help with that. So that's right there. So that monograph I put the link for is under that provider training category. You can find a lot of this stuff in provider training, but specifically that's the monograph all about how nutraceuticals lower antibodies. And they're quite effective for that. So that's the first thing is regulating, lowering iodine. And I talked about that in the thyroid reset diet. And the next thing are nutraceuticals. They can be quite effective for that from large human placebo-controlled double-blind studies. And I reference those and I cite those in that attached monograph, the one that says Fact Sheet Antibody Support PDF. Okay, I think I covered that. Good turnout, you guys. Thank you all for coming. I really, really enjoyed being with you this evening. And I'll be sure that I get the recording sent out if you want to cover this in some more detail. And also make notes about other resources that you have within TSF. So good to see you this evening and take great care. I'll connect more really soon. Bye-bye.